Welcome back to Case Studies with Caleb. We are on our second lab review in our JCB case series. We did do a Dutch review previously in a different video, so if you haven't seen that, go back and check it out. We're going to make some links from this blood work to that Dutch test. So, to remind everyone, we have a 67-year-old female. She's postmenopausal, surgically, and by age, would have been. She has migraines, weight gain, fatigue, decreased libido, and she is on 1 milligram of oral Premarin currently, as well as her over-the-counter Zyrtec and Claritin. All right. Moving forward, first section we're going to look at is her CBC. All right. So looking at her white blood cells, red blood cells, and the differential that includes that goes into depth into what those are made of. So off the bat, this is functionally low for me, this red blood cell number, 4.27. I want to get that as high as we can without pushing her into polycythemia. Right? The more red blood cells you have, the more oxygen you can carry and deliver to different or distal organs like your brain and your feet and hands. Right? So we want to get that up. But other than that, there's no sign of anemia from the MC series, although the RDW is yellow flag high. So it's not a red flag, but it's also not a green flag, right? I'm not just going to run past it, but I want to pay attention to it and I want to watch it in the future, because if it continues to go up, then it could be a sign of a brewing anemia. All right, going down into her white blood cell differential, she has an interesting neutrophil lymphocyte flippage here. That ratio should be reversed. Neutrophils are pretty much respond to anything except for viruses and even parasites, they do. Whereas lymphocytes are very specific towards the viral infections. So this could be a picture of chronic viral infection, or it could be a picture of a chronic bacterial infection, maybe sinuses, where her immune system has just kind of fatigued out and is not making as many anymore. But we'll dig into that later on if our first plans don't kind of line up, because this is a very difficult case to make just on first principles. So the other thing we have here is her high eosinophil count, which she complains of allergies, and this is likely why. So in the future, we're going to try and implement things that can calm down the mast cell eosinophilic degranulation and maybe help with her allergies a little bit. So that's on the docket for the future. Oops. From her metabolic panel, liver, kidneys look good. Fasting blood sugar is a little bit high, so we'll make note of that. But kidneys and liver look good. All right, thyroid function. Very odd picture that we have here. High TSH, so that would indicate hypofunctioning thyroid, but peripherally we have a hyperfunctioning thyroid. So this should be feeding back to the TSH, to the pituitary, to say, hey, we're good, we don't need any more, we're actually hyper, but for some reason that message isn't getting across. Now this is a very odd picture, so we're not going to take this as real. We're going to question and say, okay, if it's not real, it could just be a lab error. If it is real, we need to evaluate for tumors. So we sent her out for an ultrasound, which came back negative. Palpation was also negative, and the ultrasound didn't even show a single cyst. So completely homogeneous echo texture, nothing wrong with her thyroid. We retested later and everything was fine. So just a lab error. It happens. We are all human. Even machines have human error built in. So next up, we have our iron studies. Now, this is interesting because nothing was showing up in the H&H or red blood cells yet. But she's actually borderline iron deficient. She's not quite iron deficient yet because she still has enough iron in her serum. However, her iron storage is pretty depleted. So eventually, this is going to go down so much that serum iron will start to fall. Now, why is she iron deficient? She's not a vegan. She's not vegetarian. She eats meat. So what could it be? Maybe it's her breakdown. So it could be hypochlorhydria, not enough stomach acid in the stomach. Or it could be villous atrophy. One of the check markers for early celiac or early intestinal permeability or inflammation is low iron, because you just can't absorb it across the intestinal barrier. So we're going to look out for that. We're going to try and correlate some of these things with her presentation, maybe do some gut repair, but nonetheless, the surface problem is manifesting as low iron, and that's going to start affecting her red blood cell production and could be a component of her fatigue. Moving on, A1C, no complaints there, but we have to wonder why her estimated average glucose is 105. Because theoretically that should make an A1C higher than 5.3 if that's her average glucose. Okay. CRP, general inflammatory marker surrogate for interleukin 6, is high. So we don't know what's inflamed, but something is. Homocysteine is good. So theoretically, there's no problems with B12 or transsulfuration, but that would be a little naive to make assumptions just based on homocysteine. But at least we know that there's no nitric oxide induced issue secondary to high homocysteine. So they got that going for us. Lp(a), genetic factor for hypercoagulability based on that Lp(a) fraction on some of the LDL particles. Generally speaking, it's supposed to not be atherogenic if everything else, if all the other ducks are in a row. But, if you have LDL particle number that's high, if you have vascular inflammation or hemodynamic stress, then the proclivity to having a higher chance of CVD increases. So that's that. Now, in the future, we're going to measure in nanomole per liter, which is a little bit more sensitive to the risk. So for that intent, I think the conversion is about 2.5. But it's conservative because you can't switch from a mass to a quantity like that, especially since all the Lp(a)s have different numbers of, I think it's Kringle domains. I think that's what gives them their different mass. But nonetheless, it's high, which is going to be a pro-atherogenic mark for her for now. Next, we go to this Lp(PLA2) activity, which is, on the high side. So we know that at the endothelial border, there is some inflammation there happening either from LDLs that are carrying this enzyme or from inflammatory white blood cells that are bringing it to the atherosclerotic lesion. But, since she hasn't had an event yet, this marker is less sensitive. So, it's not really for use as a diagnostic criteria, but we know that it's going to contribute to the overall picture of vascular inflammation. So, again, it goes in the bucket of pro-atherogenic. Vitamin D is good for me. And we get to sex hormones. So if we remember on our Dutch, we hypothesized that she had low pregnenolone because DHEA was low and everything else down the funnel was low. So now we can correlate that with blood because she is quite in the dumps as far as DHEA goes. So adrenals aren't putting out much. I can't remember if she got her ovaries removed, if she had a complete hysterectomy or not. But since she's postmenopausal anyway, it doesn't matter. Her ovaries aren't going to be making much, and she's stuck with poor output. So, at least in the afternoon. because if you remember, her cortisol was great in the morning, that it was actually hyperactive. It went over the peak of what is normal. So she has good production, for the first half of the day, but then she takes a nap in the afternoon because she's so fatigued. So something's going on there from a circadian perspective that maybe we can help with some adaptogens or just straight supplementing DHEA. The sex hormone binding globulin is exquisitely high at 200 nanomoles per liter. So that's considered protective because it binds estrogen. And since estrogen is considered a carcinogen, at least by some in the field, this would theoretically bind that and reduce the chances of breast cancer and so on. So this is probably, in hindsight, it's probably a result of the Premarin. It's going to make this go up, which is also going to but sequester her free testosterone. So not a lot of that's going to be free, which, surprise, surprise, she has hardly any testosterone, which obviously correlates to potentially her low libido. A lot of people don't get their libido back even if you replace testosterone. Another topic for another time. Okay, getting into her other hormones, estradiol, 98, not bad. You'd expect that a good estrogen replacement program would get you between probably 150 and 250 is kind of my goal. So in the grand scheme of things, it's better than postmenopausal levels, but it's not optimal. Progesterone is low. She's got no way of making it. And she's not on it. No surprise there. All right. C-peptide. So this is a correlation marker with insulin, since insulin has a much lower, it's more transient in the blood. C-peptide can be a more stable marker of insulin production because it's a one-to-one created product when the proinsulin's cleaved. I didn't run an insulin on her, so we can't tell what was going on, but she probably has decent postprandial insulin release with the A1C that is that low. So we're going to have to do some digging to find out why her average blood glucose is so high. Okay. So now we get into more of the cardiovascular risk side of things. Now, if you've never run a lipoprotein fractionation, this is one of my highest ones. I think the highest I've seen is about 2750, but this one's definitely up there, especially because this woman is not obese. She's actually quite thin. So quite a discordant phenotype. I wouldn't have expected her to have high cholesterol, but also an elevated LDL-P. So her total LDL-C was 206 milligrams per deciliter, and that's distributed among these particles, which is going to end up being, on average, very small, because you've got to stuff that large mass in such a large amount of particles that each one is going to carry a relatively small amount of cholesterol and thus be dense. So the way I explain this to patients, is, since this can be kind of complicated, is that imagine you have this mass of product that needs to be distributed among your body, right? So that would be the 206 milligrams per deciliter. So that's got to be distributed. And then I describe it as a transport scenario where you want the largest, most efficient vehicles to carry the most amount that they can, right? So that you have total less vehicles on the road. So this is akin to your 18-wheeler or your transport vehicles. Large, quote-unquote, fluffy LDL particles. So I say this is the desired picture, right? You want fewer particles carrying around that large mass. On the other hand, you've got little Fiat 500s that have to carry the same mass. So you just have an extraordinary number of Fiats on the road that are carrying the same mass that these guys could carry much more efficiently. So I bridge that to say this side is more atherogenic because increased plasma residence, aka it stays in the blood for longer because the liver LDL receptors, the ApoB receptors, don't clear it as efficiently because the size is not conducive to the binding affinity, right? It has less affinity for that receptor, so it's going to be, more likely just to float on by and not bind. Okay, which then increases oxidation risk. Now we'll see later what her oxidized LDL looks like to be able to verify that this is happening. Okay, now the last point to its atherogeneity is just sheer quantity, right? Just by simple, not simple diffusion, but different gradient processes, it's more likely to be passing the endothelial wall just because of its number, right? So all LDL particles are basically in the nanometer, the nanometer range, and they can all squeak by the endothelial barrier. They're just not likely to, because why? But if they're small and there's a lot of them, they have a higher chance of getting plugged in. So that's my toddler explanation. Let's go back to our labs. Yeah, so her total cholesterol is 298. Of that, 206 is of the LDL variety, the low density lipoprotein variety. And the HDL cholesterol was 70 milligrams per deciliter. Now, her HDL particle number was 40. Now, generally that would be pretty good, but is it enough in this circumstance to actually provide more of a positive effect? It's still going to be positive, but is it enough? Total omega-3s are actually not bad. She doesn't supplement, so at 4.4%, I was kind of shocked, because I never see people that have 4.4%, or really above 3, unless they eat fish like every day, which most people don't do, or they're supplementing. Nonetheless, hers was actually decent. Boom. So there's our oxidized low-density lipoproteins. Now these are legitimately increasing risk for atherosclerosis because these guys are what induce the foam cell changes and actually develop in the plaque. So, there's if you look down at this little explanation, I think it's like 2.5. Yeah, so the range of 60 to 69 units per liter is 2.8-fold, and greater than 70 defines a population with a high relative risk, 3.5-fold the normal population. So with all of her red flags, potential red flags, it seems as though she has a pretty significant risk for atherosclerotic disease. Now I was surprised when I came to this because typically I'll see this elevated along with all of the other markers. But, it seems that perhaps endothelial dysfunction is not on the list of red flags for her, because homocysteine was good. This ADMA SDMA relationship is pretty good as well. So nitric oxide is probably not as implicated in this situation, which in the back of my mind is supporting my primary hypothesis that she has familial hypercholesterolemia. So, some genetic defect either in the PCSK9 or the ApoB receptor that's perpetuating these LDL particles in her plasma from getting cleared efficiently. Methylmalonic acid's good. I hate when the lab does this. This should just be myeloperoxidase level, not antibodies. But, so now we get down here to this estrone. So 2,430 picograms per milliliter. That is a lot. Even with ERT down here, the highest range is 488. So there's obviously, a high chance, even if she is, selectively metabolizing through that 1A1 pathway, a lot of that is still going to funnel through the 1B1 and the 3A4. So even if she had the best glutathione stores in the world, this is going to be putting a lot of stress on her glutathionylation systems and her methylation system. So if she doesn't have enough, SAMe, if she doesn't have the B vitamins, if she doesn't have the folate support, who knows what's going to happen downstream of this. So in my mind, this is increasing her risk of neoplasm just from this estrogen metabolism pathway. So we're definitely going to want to address that. And I'm pretty sure that's it. Yep, so that's it. That's our first blood lab review for our patient, JCB. If you guys have any questions, comments, concerns, you can leave them in the comment section. I'll try to get back to them. Otherwise, we are going to meet up again, or rather, I'm going to make another video for the follow-up labs to this one to see how our interventions, changed everything. For the most part, the interventions that we did for her at this point when we reviewed these were, let's move down here. So in the cardiometabolic domain, our number one priority after this was getting a PCSK9 inhibitor. So she had failed statin therapy before. She didn't do well with Zetia, and this was the next obvious choice. She met all the criteria, and so we went ahead and got a prescription for Praluent. Now the second one was, I believe, omega-3s. We started at 2 grams per day. Number 3, to support endothelial function, I believe we started some garlic extract. And I think that was it for the cardiometabolics. So the next thing we're going to focus in on is endocrine health, right? So number 1 here was HRT with DHEA, testosterone, estradiol, and progesterone. Okay, so we started that. And see, number 2 was to make sure that metabolism was going to be well, so we started liposomal glutathione, and we started diindolylmethane, and I believe that was it. So this was our first run through, right? So we started this, and we were going to give it a month to make sure that everything was going well. One of the things that you worry about with people that have migraines and giving them hormone replacement therapy is that their migraines get worse, right? So we were going to make sure that we followed up pretty frequently to make sure that we could just tinker with our dosing and really bring out the art that is hormone replacement therapy. So we'll see how this went in the follow-up video. Thanks guys for tuning in.